I've known ma'am right from my college days.
Yes, yes.
That's lovely.
Is it live, Abhishek?
Ma'am, we are live now.
A very warm evening to everyone. I, Dr. Shatabdi, on behalf of the Public Awareness Committee, I welcome you all to the academic session for today. Today is the 30th episode of our fortnightly webinars that we keep doing with each zone. Today's webinar is with the North Zone societies. And since September was the PCOS Awareness Month, that is why our topic for this session of the webinars is on and around topics related to PCOS. A very, very warm thanks to Fogsi leadership for allowing us to conduct these webinars. I now would take the blessings of the Lord. Abhishek, if you
Yes,
could
ma'am.
please play the Ganesh Vandana.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्तिः.
Thank you. We will move ahead. Once again, thanks to Foxy leadership for allowing us to conduct these webinars. I would now request Priyankur, the chairperson of Public Awareness Committee, to kindly introduce the program as well as introduce our guests of honor. Over to you, Priyankur.
Thank you so much, Shatabdi. It's indeed a pleasure for all of us to welcome you all once again to this program, the Core Connect program that we have been doing, and this is the 30th episode of the program. Jaideep sir, as we all know, has always stressed on the fact of continuum, and I think that is what we always strive to do, and that is why we have reached this milestone of the 30th program today. I would like to thank, of course, the Foxy leadership, as Shatabdi was saying, for allowing us to do the program. Dr. Jaideep Tang sir, Dr. Madhuri Patel ma'am, Ajay Manes sir, Parikshit sir, and Dr. Kalyan for always being an support system. Our coordinators have worked wonderfully and they have put in a lot of efforts for the programs always, Dr. Monica, Dr. Shatabdi, and Dr. Atalia. And we have our ever loving and ever, so sweet and ever blessing, or we have the blessing always of our conveners, Dr. Anita Sabarwal ma'am and Dr. Vidhu Motkil ma'am. Our guest of honors today are none other than Dr. Ashok Kumar sir and Dr. Uma Singh ma'am. We welcome both of you, ma'am, to the and sir to the program. We have wonderful talks today. We have our talks by our speakers, Dr. Kuldeep Jain sir and Dr. Seema Pandey ma'am. And to the chair the sessions, we have Dr. Anita Sabarwal ma'am and Dr. Anshu. And we have Dr. Vidhu and Dr. Alka Sethi ma'am who will be chairing the second talk. The panel will be moderated by Dr. Bharti and Dr. Shatabdi. Dr. Rakhi ma'am, who has been the Endocrinology Committee chairperson, will be the expert for this panel. And we have our brilliant panelists with us today, Dr. Krishna Dahiya ma'am, Dr. Nishi Garg ma'am, Dr. Amita Gupta ma'am, Dr. Madhulika Singh ma'am, Dr. Priyanka Garg, Dr. Kia, Dr. Kiran Chandra ma'am, Dr. Alka Yadav ma'am, Dr. Sinal, and Dr. Parul Khanna. So I welcome all of you to this program. And I would first of all would like to, of course, welcome our guest of honors today, Dr. Ashok Kumar sir and Dr. Uma Singh ma'am. I'm not sure if they have joined us already. Shatabdi, will you follow up with sir and ma'am? I'll introduce them, but once they join, we'll take their blessings.
Surely.
Huh?
Surely. I'll do that. I'll do that. I'll follow up.
Yeah. Dr. Ashok Kumar sir is the Director, Professor and Head Department of OBGYN at the Atal Bihari Institute of Health Sciences in Delhi. He is currently the President of the AOGD and is the Organizing Chair of the AICOG that's going to happen in Delhi in 2026. He is also the Vice Chair elect of ICOG. So I would like to welcome sir. And with him, we also have, as our guest of honor today, is Dr. Uma Singh ma'am. Dr. Uma Singh ma'am, as we all know, has been a teacher of many of all the seniors in Foxy and around as well. She is currently the Senior Technical Director, University of Manitoba. She has been the ex-HOD and Dean of the prestigious KG Medical College, that's KGU in Lucknow. She's been a WHO Fellow in Gynec Oncology, President of the UP chapter of Gynec Oncology, Vice President of AGOI, and has held many, many prestigious posts. Overall, I think to introduce her, we can just say that she has been a teacher of many, many of us. And it's such a pleasure to see ma'am and welcome her again. So, ma'am, I see that you are already here. I request you to kindly say a few words of blessings to everyone present over here.
Yeah, so good evening, everybody. Thank you so much. It is so nice to be, after putting in something like 38 years of being faculty, it is so wonderful to be acknowledged as teacher. The best thing probably being in this profession is that apart from being a consultant, a physician, you also are a teacher, and courtesy teacher, you get a wealth of these students who have passed out at some time or other. And this wealth is probably unmatched, unparalleled. Thank you so much for introducing me that way, because I think that that's the best identity for anybody who's been there in teaching profession understands that. Now, coming to this webinar, it is a great pleasure and privilege for me that I have been included as guest of honor. I feel these webinars, when they do a zonal concentration, they reach out to all the people, to all the doctors in such a significant, robust manner that everybody gets that sense of being involved, because it is zonal, so they all feel. And having local people gives them a little more connectivity. I am thankful to Fogsi for leading these set of webinars, and I'm absolutely impressed by the variety of topics that are being covered, the wide reach out of faculty, the brilliant faculty which they involve is amazing. And I think these give platform to the coordinators, to the presenters, to the panelists, everybody to make their presence felt, which often face-to-face conferences are not able to give as many opportunities. So these Fogsi-led webinars give opportunity to more and more people in different capacities, which is like capacity building and which are useful for future generations to come. I absolutely am thrilled. I extend my gratitude to Fogsi, and I wish all the success to this webinar also. I'm pleased to be here once again. Thank you.
Thank you so much. Thank you so much, Uma Singh ma'am. It was a pleasure listening to you, and it's always a pleasure seeing you online or offline as well. Thank you so much, ma'am. Dr. Ashok Kumar sir hasn't joined yet, so I think we will take his blessings once he joins us. Shatabdi, I request you to kindly introduce the chairpersons and move on with the scientific session. Dr. Kuldeep sir is already here, and I think it's there. Yeah, sure. Thank you.
Yes, I'll go ahead. Ashok sir will be joining us in a while. As and when he joins, we'll take his blessings as well.
Sure. Thank you.
Yeah. Our first session for today is a talk by Dr. Kuldeep Jain sir. It's on PCOS and infertility. PCOS is a very, very pertinent topic in today's times. Our chairpersons for the event, for the session are Dr. Anita Sabarwal ma'am. Dr. Anita Sabarwal ma'am is a senior consultant at Delhi. She is the president of FOX. She is also the North Zone coordinator for the Public Awareness Committee of Fogsi. She has various awards to her credit, as well as she has various publications to her credit. Welcome you, Anita ma'am. Our next chairperson for the session is Dr. Anshu Kakkar ma'am. Dr. Anshu Kakkar is a consultant at Kakkar Eye and Maternity Center. She is also an ex-associate professor at Shri Guru Ram Rai Medical College, Dehradun. She has been the immediate past secretary of Dehradun Obs and Gynae Society, as well as the secretary of International Society of Gynae Plastic Surgery. We welcome you, Anshu ma'am. I think Ashok sir has joined. If Ashok sir, if you could have your blessings, and then we will carry on with the session.
Yeah, am I audible?
Yes, sir. Yes, you are.
Okay. So thank you. First of all, good evening to all of you, and thank you, Dr. Priyankar, and Dr. Monica, for giving me this opportunity. Yes, Public Awareness Committee is a very important committee, and they are doing a lot of important work. And I think we all of us need public awareness one or other time to spread the messages or spread the knowledges about whatever information we have or whatever we want to achieve or we want to get. So it is an important role they are playing for all of us. And congratulations, Dr. Prenkar, for your excellent work and getting the acknowledgement from Foxy also in this year as a best society of Foxy. So congratulations. And uh, only one comment I will make here. Otherwise, you are doing a lot of good work and everything is fine. And you have given me this opportunity for interacting with your delegates today. But try to have some topic of obstetric interest also in your webinar or in your program, or I will say otherwise also that try to do public awareness or spread the message about obstetrics also, pure obstetrics, because that is also a important part of our specialty. And uh, we should be promoting and doing lot of uh, spreading the knowledge and everything for obstetric branch, pure obstetric branch. We have other things off and on, and we are regularly participating in other type of activities and other subjects also. But I think you should take it, like I was seeing your program today also, uh, everything is on some other topic. So try to take care of these type of things. And with these words, I thank you once again, and congratulate all of you. And I hope that with your today's webinar, our participants will be benefited. Thank you very much.
Thank you so much, Ashok sir, for the wishes. Sir, thank you so much. It means a lot. It was a team effort completely who worked a lot, and that is why probably we could achieve the best committee award. Thank you once again, sir, for that. And sorry, we actually had introduced you before you had joined, sir. So I directly told you to start speaking, sir. And thirdly, sir, you talked about the topics, sir. So basically, what we do is we usually select the topics based on the theme on which that month is, like this, whatever we celebrate. And this month, since it's a PCOS awareness month, so we took the topic of PCOS, sir. We do select obstetric topics based on whichever month it is, sir, and based on that, we do take it. But then, yes, we will keep it in mind, and henceforth, we will make sure that we have some obstetric topic in most of the webinars, which is usually a topic of interest for most. Thank you so much once again, sir, for joining. And we are wishing you all the very best for your preparation for AICOG, and we are going to definitely have a great time there as well. Thank you once again, sir. Shatabdi, you can take over.
Yes.
And Anita ma'am is there, so you can request ma'am or someone introduce Kuldeep sir, and we can start. Thank you.
Yes, yes. Thank you, Priyankur. Thank you, Ashok sir, for your words of blessings. Very good evening to Anita ma'am. Ma'am, if you could please introduce Dr. Kuldeep Jain sir. He is our first speaker for the session. And sorry,
Sure.
I've already introduced you before you joined. So if you could please introduce Kuldeep sir.
Thank you. Thank you. I'm already in your heart, so no need for any more introduction. Thank you so much. Good evening,
Thank you.
everyone. It's really a great honor now because taking part in that public awareness committee, which has just had a big award at Foxy office in Mumbai. So congratulations to our dear Priyankur and the whole team. And of course, I'm going to introduce our own Delhi star, rather superstar, Dr. Kuldeep Jain, who's the director of KG IVF and Laparoscopic Center at Delhi, which I visited often. It's in East Delhi, a big center. And Sir is known to everybody. I think he needs no introduction. He is such a well-decorated person. He's the founder secretary and past president of the very prestigious Indian Fertility Society. And of course, he's the editor-in-chief of Fertility Science and Research, and he has chaired so many committees, even the Fusion, very famous one on 2024. And he has delivered, I think, numerous lectures and orations. and recipient of Lifetime Achievement Award. So now I think everybody is very eagerly waiting to hear from our own Dr. Kuldeep Jain, sir. So over to you, sir. Dr. Kuldeep Jain, sir.
Thank you, Dr. Anita, for very kind introduction. Uh, it is the pleasure actually to be joining this platform, and I must thank Dr. Priyanko for having me here. I know I have worked with him in some of the major conferences like Fusion 2022. He was very, very helpful. So thank you, Priyanka, and congratulations, and I wish all the best uh, to you and your team for the rest of the tenure. Today, actually, I am going to speak on a very basic subject, which is really pertinent to all. It is not only the infertility subject, it is pertinent to everyone who is practicing obs and gynae, because PCOS is uh, full of dilemma, and it starts from the adolescent, continues through reproductive life, and even during menopause, you get the different type of presentation of PCOS. So it is not only infertility, it is a disease of lifetime. So let us, I will just focus on few important uh, basic things, because uh, you have to really define what you want to talk in PCOS, because we can conduct a whole 2 days conference on PCOS. So in the next 20 minutes, I am going to touch upon the basics of diagnosis, how you should manage when they present in different time of period, and so on. So at least uh, some take-home message will generate, and I am really sure that audience will get some benefit from this talk. Let us consider some facts about PCOS. We know that it is a complex endocrine disorder, and as I already mentioned, it affects women in all age group. All age group means adolescent, childbearing, as well as menopause. It is characterized by increased androgens and ovulatory dysfunction. So that is the main two things which we need to understand. It is one of the leading cause of ovulatory infertility and hirsutism. And it is women with PCOS actually having very increased risk of miscarriage, hyperlipidemias, type 2 diabetes, metabolic syndrome, cardiovascular disease, and endometrial carcinoma. So you see the vast effect on the woman health when we talk of PCOS. So it is not only limited to infertility, that you must remember as a obstetrician. The patient will continue to come to you till she achieves her menopause and beyond menopause. Millions of women are suffering from PCOS. This is a depiction of that. And when you talk of prevalence of PCOS in India and its association with obesity, you can see here that 60% of Indian PCOS women are obese. This is very important, actually. So presentation is uh, differing from the one area to other area. And 36% of women of reproductive age are suffering from PCOS. This is whenever you see a lady like this, you always think that she may be having a PCOS. And what about these obesity, which can present in these patients? And these patients, they do really have multiple problems. It is not only obesity. They are carrying the high risk of diabetes, hypertension, and later on other metabolic syndromes. It is not only obesity. These young girls, they are lean and thin, but they are suffering from PCOS. They are having PCOS. So, and these girls, they are really difficult to treat. Obesity, obese PCOS is slightly better as far as the treatment of infertility is concerned, because they respond to your stimulation slightly better than the lean and thin PCOS. Now, there it is actually the combination of familial factors and environmental factors, lifestyle, whether you are smoking or not, and that increases the risk in PCOS. This is something, the presentation basically, when you are dealing with adolescent PCOS, they will be presenting to you like menstrual irregularity, very common in adolescent, uh, and acne, hirsutism, and hair loss. So these are the primary concern in adolescent PCOS. When you move on to the reproductive age group, it is infertility primarily, and if they conceive, there's a increased risk of miscarriage, so they can present multiple miscarriages, and then you tend to attend them, or during pregnancy, they are at very high risk of PIH and GDM. And when you move on to the menopausal age, they may present to you as metabolic syndrome and carcinoma endometrium. So you see here that the presentation in different lifespan is different. But one thing is very common in many patients, that is obesity. This is one exercise we did in Fogsi opinion group meetings in 2018, and I was deeply involved in this program, and we developed a PCOS tree for practicing gynecologist. That should have come very handy, but unfortunately this was not circulated very properly, but this is still available in Foxy website. So anyone who can reach to this PCOS tree, this is a really wonderful exercise which we did in 2018. Now here you see the flow. PCOS, it is the commonest endocrinopathy. Worldwide prevalence is 5 to 15%. And we know that there are 4 phenotypes. We are now thinking of revising this phenotype, because this is not actually covering all the phenotypes. We are having 2 more phenotypes which needs to be added, and there is a international exercise going on which is trying to change the way we understand PCOS. Major symptoms are related to hyperandrogenemia, ovulatory dysfunction, and polycystic ovarian morphology. When we talk of adult PCOS, there are 2 types of patients who are coming to us. One is seeking fertility. This is the major group, but there are other patients who are having completed the family, but they are coming to you. And then in perimenopause, menopausal PCOS, the problems are different. So how you go about with these patients? We need to diagnose them. We need to investigate management, long-term follow-up, and consequences. As far as the diagnostic criteria, we are still using Rotterdam Consensus of 2003, where 2 out of the 3 criteria needs to be fulfilled to put a patient in the category of diagnosis of PCOS. Patient should be having oligo or anovulation, hyperandrogenism, clinical or biochemical, and ultrasound feature of polycystic ovaries. Now, out of these 3, if 2 are there, you can put that patient in the bracket of PCOS. Okay. Now, AMH is one thing which has been pushed actually in the diagnosis, but still it is not considered as a diagnostic criteria, but probably it is more helpful in the management of PCOS. Coming again, there are a lot of changes over the period in the diagnosis ultrasound criteria of PCOS. So this is just an update. At least one of the following should be there. Now here it is written 15 or more follicles, but because now we are having a revision, And some of the studies have suggested it should be more than 20 because of the high resolution ultrasound available. So that has not changed yet, but yes, it is going to change. 2 to 9 millimeter in diameter. The volume increase is there, more than 10 cc volume is one of the criteria. And if there is one follicle more than 10 mm, then scans should be repeated before putting this patient as PCOS. Any follicular cyst or any corpus luteum in the ovary, you cannot diagnose PCOS in that particular cycle. Okay. The distribution of follicle, which was previous criteria, are not taken into account anymore. Description of stroma again is not taken into account anymore. How does lifestyle modification helps in management of PCOS? Yes, we always say that lifestyle modification is one of the prime important area. This is one paper which I am quoting. The modest weight loss can restore ovulation in 23.8% of patients, and it can increase pregnancy rate up to 77.6%. This is an old study, but yes, it is true. There are not many more studies have come up as far as the lifestyle modification and pregnancy outcome or PCOS outcome is concerned. There are very few studies. We talk a lot on lifestyle modification, but when you go search the lifestyle modification, studies, controlled studies are not many, but it works. It actually increases the self-esteem, anxiety is related problem, and mean depression score is reduced when you are suggesting the lifestyle modification. Now, how there is no limit. Actually, the people have developed PCOS diet plan. They have suggested a lot of exercises, but our focus is always like whatever is comfortable to the patient. The main aim is reduction of 5 to 10% of the body weight. And that really helps in a lot of patients in reducing the hyperandrogenism as well as in the menstrual cycle. Like again, if the lady is smoking or eating junk food, then certain these are the things which needs to be taken into account. Suggestion of yoga, healthy and happy living is certainly part of lifestyle modification, but how much you can impress upon that depends on your personal personal approach to these patients. I was talking of, I will not go into the detail of all these diets. So these are some of the important things. Now, patient who is in reproductive age group, diagnosis, I have already said, biochemical determination of testosterone is evidence level 4, AMH grade B evidence level 4, and progesterone withdrawal bleed evidence level 4. OGTT is one of the important important investigation in the diagnosis, but it is actually in the management, but OGTT is preferable to be done in all cases. Now, patients who are seeking fertility, preconception counseling is very, very important in these patients, and one has to go for positive counseling, not negative counseling. Okay, that is very, very important. Long-term risk needs to be told, but not in negative manner, because they are a evidence. Regarding diet, again, you have to impress upon in a positive way. And length of the procedure, because that is one question which people always ask, how much time? So again, that needs to be told to them in a positive manner, because you cannot restrict the treatment of PCOS for 3 months or 6 months or 1 year. Okay, it is a continuous treatment. Even the patient conceives, she will continue to get treatment. Now, what about lifestyle modification? Again, this is grade A evidence. So needs to be suggested. Calorie restricting diet, 500 calorie in physical activity of 60 minutes per day is recommended actually. Cessation of alcohol consumption, coffee intake, cessation of smoking, again very important. And there is certainly positive role of yoga as far as the bariatric surgery is concerned. When BMI is more than 40, then only one should suggest bariatric for PCOS. Otherwise, it is not recommended. Not seeking fertility, again, lifestyle modification, menstrual irregularity can be treated by giving the progesterone and regular follow-up in these patients who have completed the family, looking for the metabolic syndrome and carcinoma risk. Ovulation induction, I am not going to deal in detail because it is, I think there's another lecture, but I'm just giving the outline here. Medical management, clomiphene citrate remains first line drug, but of late, the letrozole is suggested to be a primary drug for PCOS by many guidelines, and it is recommended to switch on to the letrozole when you are considering a oral ovulation induction. If you are using CC, then you have to keep in mind CC failures and CC resistance. That needs to be taken into account, and you switch over to the other protocol. Role of surgery is under the bracket. It is not a primary treatment for PCOS. It is restricted to very resistant PCOS who are not responding to even your gonadotropin. It is a good therapy, but it is not a primary therapy. So that you need to keep in mind. Then if you are doing a surgical management like LOD, you have to restrict to formula 4 that is suggested in the literature because of the fear of over-treating these patients. So what are the factors which influences ovulation induction? Female age needs to be taken into account, ovarian reserve and BMI, obesity. The problems in PCOS and why CC resistance occurs because there is disturbed steroidogenesis, large number of small antral follicles which are producing, which are disturbing actually the hormonal milieu, and there is continuous chronic tonic high serum concentration of LH, which leads to the premature luteinization, low pregnancy rate, and high miscarriage rate. So this is in summary. Hyperinsulinemia is there, increased ovarian androgens, decreased SHBG, increased LH, leading to anovulation. You require more FSH for induction. There is multifollicular response, so risk of ovarian hyperstimulation, decreased pregnancy rate, and increased miscarriage rate. Letrozole is slightly different because we are having a negative feedback intact, so there is a monofollicular growth. As soon as estrogen rises, there is suppression. So that's why monofollicular growth is there. No ER downregulation is there. So there is no target. It is only targeted effect, no peripheral effect. And augmentation of FSH receptor also there. So there is increased sensitivity to FSH. So when you are combining FSH, you require less dose. This is our experience on letrozole. And here you can see it is when you combine letrozole with FSH, rather than using only FSH, you can reduce the FSH dose. And the pregnancy rates are almost same. And cancellation rates are also decreased. Protocol, I am not going into the detail, but this is one protocol which is very good in these patients, very effective in resistant cases when you combine letrozole with FSH. Less gonadotropin, cost effective, better endometrial growth, and comparable conception rate. I am not going into the detail. So now, what about the pre-treatment combined oral OCPs? It is a grade B evidence. Melatonin, N-acetylcysteine, myoinositol, again they have emerged as a alternative to in other insulin sensitizer, which is glyciphase. Gonadotropin are second line treatment. So that should be offered when your oral ovulations are not functioning or patient is not getting pregnant. So either CC failure or CC resistance. This is grade A evidence. And when you are using gonadotropin for ovulation induction, chronic low dose protocol should be used to avoid any ovarian hyperstimulation. IUI, not routine treatment for these patients, but at some stage you have to introduce IUI. And if the patient doesn't conceive, then ART is third line of treatment. And luteal phase support is always required in PCOS because of the difficult steroidogenesis. Role of minoxidil, melatonin, newer drugs. So there are multiple newer drugs. I'm not again going to in the detail. Probably that will be covered in the next lecture. This is very important. Minoxidil, when you compare minoxidil and metformin, minoxidil is preferable over metformin because of two reasons. It is well tolerable, minimal side effects, and slightly better, comparatively better pregnancy rate and decreased miscarriage rate. So finally, this is the consensus how PCOS patients in infertility should be behaving. Clomiphene citrate is now replaced. Actually, this is older slide. So this is replaced by letrozole. If your patient doesn't conceive or doesn't respond, go on to the gonadotropin or laparoscopic ovarian drilling. That is, again, I have already told, that is third line. And if your patient doesn't conceive, then go for IVF. This is my last slide. This is a meta-analysis of 26 randomized clinical trials. And here you can see HMG therapy results in higher pregnancy rate than other therapies. Pregnancy, live birth, and ovulation rates are significantly higher in those patients where you are combining insulin sensitizer with oral or gonadotropin group. Abortion rate in this group is slightly better when these patients are on insulin sensitizer. So in conclusion, you have to be very focused when you are dealing with these patients. You have to be very calculative depending on the BMI, depending on the previous response, depending on the age, duration of infertility. You have to choose your protocol. Long-term consequences are always there, and you have to keep in mind the obesity, hypertension, dyslipidemia, and obesity. Increased risk of endometrial cancer. So again, weight loss followed by oral drugs are recommended. Metformin needs to be added, gets better result. Support low dose FSH or combined therapy is always better. Lifestyle modification should be suggested, and of course other drugs remains a little gray area, so I am not going to discuss. Thank you very much for your kind attention, and I hope I am able to give some of the take-home messages for the audience. Thank you. If there are any questions, I will be happy to take.
Thank you, sir. Thank you, Dr. Kuldeep Jain, sir, for the wonderful lecture. And it was really updating and very informative and interesting. And I really like that you said about lifestyle and the positive counseling and the yoga. These three things are really very, very much required. And I feel if lifestyle management they do, obesity can really be taken care of. So thank you so much. Now over to Shtabdi. Sir, you could hear you had a phone.
Yeah,
on
I
the
could.
phone.
Yeah, thank you for your
Yeah.
comment, Anita.
Yeah. So I just mentioned that lifestyle can really take care of obesity if really taken into very seriously. And of course, the positive counseling.
Yeah,
And
many times when you are
counseling,
when you are counseling for lifestyle modification, the young girls, next time she will not come to you. So that's why it has to be in such a way that it is
Absolutely.
doable and they understand the problem. So I think that is very, very important part of PCOS management.
Right, right. Dr. Parul.
Good evening, ma'am. Good evening, sir.
Dr. Shtabdi, where are you?
Ma'am, she is having some connection issue. She is joining in a
Okay.
while.
Right, right. So I think we are through this lecture. And any other comments from my co-chairperson? Otherwise, we can go on with the next session.
Ma'am has joined. Shatabdi ma'am has
Yeah.
joined.
Okay, okay. Okay, Shtabdi. Dr.
Thank you, ma'am.
Shtabdi,
Thank you so much, ma'am.
yeah. Thank you so much. It was really wonderful session. Thank you.
Wishing you a belated happy birthday, ma'am, on behalf of all of us.
Thank you so much. My birthday will go on for 1 week. So anybody who hasn't wished, please wish me in this coming week. Thank you so much.
You're most welcome, ma'am.
Bye.
Wonderful to have you, ma'am. Bye, ma'am. Yeah. Thank you, ma'am.
Okay.
We will
Yes.
move on to our next session. Our next session is on polycystic ovarian syndrome and ovulation induction. Our chairpersons are Dr. Vidhu Modgil, ma'am, and Dr. Alka Sethi, ma'am. Actually, our speaker for today was Dr. Seema Pandey, ma'am, but Dr. Seema is unwell, admitted on IV fluids. So, ma'am won't be able to join. We will be playing a recorded talk of Dr. Sujata Kar, ma'am, on the same topic. So, can I have the slides of the chairpersons? Abhishek? Yeah, Dr. Vidhu Modgil, ma'am, is a director and senior consultant at Suman Hospital, Ludhiana. She is a gynecologist as well as an infertility specialist. Ma'am has various awards to her credit. She is a lifetime member of various organizations. Also, the North Zone coordinator of our Public Awareness Committee. Our next chairperson is Dr. Alka Sethi, ma'am. Dr. Alka Sethi, ma'am, is a former superintendent and consultant gynecologist at Cantonment Hospital at Jhansi. She has been the president of IMA in the years 21 to 22. And she also has the gold medal in OBS and Gynae and Basu scholarship and in total 6 medals. Welcome, ma'am.
Thank you.
Ma'am, I would request you to kindly introduce Dr. Sujata Kar, ma'am, as we'll be playing her talk.
Sure.
Over to you, ma'am.
First of all, I'll thank Dr. Priyankur for including me in his Public Awareness Committee talk. And the topic is very important and very nicely covered by our previous speaker. And now we have Dr. Sujata Kaur. She's a practicing gynecologist endoscopy in ART for the last 27 years. Her major achievements are she's the best graduate with 7 gold medals in MD, MBBS, credited with the first test tube baby of Eastern Orissa. She has many awards to her credit. Pariksha Award for Women Achiever Odisha 2019 from Honorary Governor. She has so many publications, 15 original publications related to PCOS and male infertility in PubMed. She's written many chapters on books and newsletters. She's a reviewer of many international journals. Present, she is holding the position of Honorary Secretary of ISAR India and EC member of IAGE, ISSRF, PCOS Society, FPS of India. We welcome you, Dr. Sujata. Please, we are waiting for your deliberations. Thank you.
And greetings from Bhubaneswar. Thanks to Fogsi for giving me this opportunity. My topic today is oral ovulogence for ovulation induction, which is best for PCOS women and why. Now, all of us are aware that 600 to 650 oocytes undergo atresia every month for one single oocyte to be selected dominant and to ovulate. Now, this is what happens in normal physiology, but in PCOS, there is a chronic persistent state of anovulation where all the gonadotrophins and sex steroids are in a steady state. We do not see the normal dance of the gonadotrophins and sex steroids as we know in the normal menstrual cycle. And now we know that anti-Mullerian hormone is intricately associated or is responsible for this disordered folliculogenesis of PCOS. In today's meeting, I will not I'll not have the time to go into the details of this, but to give you an overview, AMH and PCOS are intricately related in pathophysiology. Serum levels are 2 to 3-fold higher in PCOS women and 5-fold higher in follicular fluid of PCOS women. It is consistent with increased antral follicles of polycystic ovarian morphology. Apart from number of follicles being more and therefore AMH being more, it is also very much possible that each follicle secretes more AMH than normal. Some studies have reported as high as 75-fold higher per follicle compared to a normal ovulatory women. So AMH will certainly has a role in pathogenesis, and not only AMH is a marker of polycystic ovarian morphology. Now, PCOS women, we know that ovarian stimulation or ovulation induction is a challenge. It's almost like walking a thin rope between too much or too less. So ovulation induction certainly is a challenge. Today we are going to talk about oral ovulogens, which are pharmaceutical agents that initiate, augment, modulate hormonal and gametogenic response so as to result in the development of a dominant follicle and thereby get ovulation in the cycle that you do ovarian stimulation. So usually using oral ovulogens results in a mild form of stimulation. Oral ovulogens can be used in chronic anovulation like in PCOS, which are the vast majority of cases, maybe about 80% of cases. You can use them for mild ovulation in normal responders in whom you are doing IUI, or it can also be used in mild stimulation protocols of IVF. The aim, of course, is to optimize the selection of the drug for best protocol and lowest risk. Now, what are the oral ovulogens? They are usually anti-estrogen, aromatase inhibitors, clomiphene citrate, tamoxifen, raloxifene, and letrozole or anastrozole. Now, let us have a look at how mechanism of action of each of these oral ovulogens. The clomiphene has been in use now for almost 50 years. And it's very easy, it's well known, it's been used for a very long time. It has minimal side effects. Dose flexibility is there. You can start from day 2 or up to day 5. You can start. It has 2 stereoisomers, ZU and N-clomiphene in various percentage in this ratio. Tamoxifen, raloxifene is not as commonly used as clomiphene citrate, but yes, there are situations where you use them. Anti-estrogenic, it is an anti-estrogen with weak estrogenic activity, and these primarily act on the HPO axis. Now, clomiphene citrate, you will all agree that apart from use of clomiphene citrate, which has been tremendous over so many years, abuse of clomiphene citrate also has been rampant amongst gynecologists. Clomiphene citrate induces gonadotropin release from the pituitary gland by binding to the estrogen receptors in the hypothalamus, blocks the negative feedback of estrogen, leads to increased and prolonged FSH-LH secretion. It is weak and prevalent anti-estrogenic effect on sensitive tissues like endometrium and ovaries also. Now, ovulation rate with clomiphene is very good, about 70 to 85%. Pregnancy rates are 30 to 40%. Miscarriage rates are almost up to 20-25%. Multiple pregnancy rates are high, stands at 8%, and single live birth rate is about 25%. And in a large number of patients, we also see clomiphene citrate resistance. So the key points are it's centrally acting, therefore can result in multiple follicles and therefore theoretical risk of OHSS. It has an adverse effect on endometrium and cervical mucosa. It has a long half-life and slow clearance from the blood, and discrepancy between ovulation rate and pregnancy rate and live birth rate. Now, current recommendations for clomiphene citrate is that it should be maximum one should limit a patient's lifetime exposure of clomiphene citrate to about 12 treatment cycles. Tamoxifen also is a SOM used about 20 milligrams from day 2 or day 3. I think the best situation where you may use tamoxifen instead of clomiphene citrate would be as an alternative to CC if the CC is not responding, or if there is inadequate endometrial thickness with clomiphene citrate. But now for vast majority of situation, letrozole has taken over. Letrozole is an aromatase inhibitor. It results in an acute hypoestrogenic state. It releases the ovary from the HPO negative estrogen feedback. Advantages of letrozole are many. It has a short half-life, acts on the ovary, no negative side effects on endometrium and cervical mucus, and usually results in a monofollicular ovulation because it does not result in sustained increase in the FSH levels. Optimal dose developing studies were never done for letrozole. Based on current data, the optimal dose is probably 2.5 to 5 milligrams. A higher dose can be used. It is very well tolerated with very less side effects. Now, if we have to choose between clomiphene citrate and letrozole, can we make the right choice? I think for vast majority of us, it has become a fact that we use letrozole as a first choice. But is it also supported by evidence? Yes, it is supported. I also published a randomized controlled trial comparing the two. But major 4 publications were the iconic one, multicentric trial, a large trial from Richard Legro's group, which showed very clearly that ovulation rate, primary, the live birth rate, clinical pregnancy rate were all higher with letrozole compared to clomiphene citrate. The congenital anomaly rate was also shown to be clearly lower in letrozole group. And the best part was that when in the group analysis, letrozole was better than clomiphene in all BMI groups, low BMI as well as higher BMI. And after that, many meta-analysis and systematic reviews and IPDs were published. I was part of them. 2 of the major publications that showed clearly that letrozole is a better drug. And of course, the new international guidelines also tell us that letrozole is probably the first-line ovulation induction drug. And this was another publication in Human Reproduction Update in which I was a co-author, in which it was shown that probably we should personalize our approach. Letrozole may be as good as clomiphene citrate plus metformin, or rather clomiphene plus metformin may be as good as letrozole alone in certain group of patients, especially women who have high testosterone or more androgenic. For them, letrozole might be better. But those who are more hyper insulinemic or insulin resistance is higher, they might be better with clomiphene plus letrozole. And therefore, at least for our situation, we must think that clomiphene plus letrozole also is a good, clomiphene plus metformin is a very good choice for us. Gradually, as we have started using more and more letrozole, we've started to also understand that many women are resistant to letrozole. And now with studies have shown that women who have very high AMH levels, they are probably almost always resistant to all oral ovulagens and certainly also to letrozole. So women who are obese, hyperandrogenic, and who have very high AMH levels and very high ovarian volume, they are probably going to be resistant to letrozole. And so therefore, many other protocols for letrozole use has come up to use letrozole in a manner that can, if this conventional dose of 2.5 or 5 for 5 days fails, there are people have advocated a prolonged 10-day letrozole protocol, or one can increase the dose to 7.5. One can use a stair-step protocol by using 2.5, 5, 7.5, and 10, etc. So many other protocols have also come in, which can be used if the conventional dose of letrozole fails. Now, no discussion on oral ovulogens will be complete unless we discuss the role of insulin sensitizing agents. So what is their role? Yes, certainly many years have passed since metformin has been there, and metformin is now a very solid part of our prescription for PCOS women for ovulation induction, especially in Asian Indian women who have very high body fat, very high visceral fat, and very high insulin resistance. And it has also been shown in literature that yes, clomiphene citrate with metformin or letrozole with metformin is a very good option where you are expecting letrozole resistance or clomiphene resistance. So the key takeaways from my talk today is, as expected, all PCOS women have different phenotypes and genotypes. Pre-ovulation induction assessment of PCOS phenotype and metabolic disorders is very much necessary if we have to do ovulation induction, which means all PCOS women before ovulation induction, we must check their metabolic profile also, which means fasting blood sugar, postprandial glucose challenge test, then lipid profile, their BMI, presence, absence of acanthosis, etc. We should be checking vitamin D levels, etc. can be done to look at their metabolic, what is their metabolic phenotype. So letrozole is certainly the first line ovulation induction drug, apart from the fact that we are not talking about lifestyle changes, which is the first type. But today's discussion is only about oral ovulagens. So letrozole, clomiphene plus metformin also may be as good as letrozole in select cases, and especially in our scenario, it might be a very good choice. Letrozole plus metformin is also an excellent choice where needed, although we do not have too many publications in this combination. We have many publications with showing clomiphene citrate alone or clomiphene citrate plus metformin, but we do not have too many publications with metformin. Letrozole can be prescribed in various regimens, like I showed you, if it is resistant to the conventional dosage. Metformin has excellent data to support. Now, current data also is coming out to show that metformin dosage can be titrated according to the BMI. But then women who are not necessarily glucose intolerant also should be prescribed metformin to improve their chances for ovulation induction. Inositols, again, are very much there in the market, and very much being prescribed. But again, it is comes in the category of a nutraceutical. It is available off-label in a free market. Anybody can buy it. It certainly has benefits and improves the metabolic parameters in cases of PCOS women. But how far it is effective in improving the reproductive outcome, along with other oral ovulagens, we still have lack of data supporting inositol, and their metformin would definitely come in first where ovulation induction is concerned. And also inositols are expensive compared to metformin, but the biggest advantage of inositols are that they're very well tolerated, and patients very often have already started it on their own as a nutraceutical, as a nutritional supplement, if they know that they have PCOS. So that is about oral ovulagens and what are best and how we can use them in cases of PCOS for ovulation induction. Thank you so much for your kind attention.
Alka Sethi ma'am, if you're there, if you could have your expert comments, please, ma'am.
I think Dr. Sujata Kaur has covered all the basics, the stepwise, first, second, third, fourth line of treatment. She's covered up very nicely, and especially it's an eye-opener for the youngsters, for the juniors. And of course, there are many more drugs, many more advantages and disadvantages of all these drugs. But very basic and very fundamental things she's covered. So it's really a very good talk, and I'm sure all of us have really benefited. Any questions?
Ma'am, no questions as of now.
Then we can proceed further.
Thank you so much, Alka ma'am. Thank you so much for your time. Thank you. We would now proceed to our next session. Our next session is a panel discussion. It's on case-based discussions on PCOS. It will be moderated by Bharti ma'am. I was supposed to moderate with her. I have to go for a protest, so I will not be able to do that. So it will be moderated by Dr. Bharti ma'am, and our expert for the session is Dr. Rakhi Singh ma'am. Can we have the CVs, please, Abhishek? Dr. Bharti ma'am is a fellow in reproductive medicine and infertility. She is an assistant professor in OBGY at PGIMR Chandigarh. She has various special achievements to her credit. She has worked as a COVID-19 nodal officer. She has 50 publications to her credit. Very, very happy to have you here. Welcome, Bharti ma'am.
Thank you. Thank you.
Yeah, next CV, Abhishek, Dr. Rakhi ma'am. Our expert for the session is Dr. Rakhi Dhawan Singh ma'am. Ma'am is the director of Abalone Clinic and Maternity and Fertility at an IVF center at Noida. Ma'am is the chairperson of Endocrinology Committee of Fogsi, has been the vice chairperson of UP State ISAR, as well as peer reviewer for Journal of Obstetric and Gynecology of India. Ma'am has various awards and publications to her credit. Welcome, Rakhi ma'am. Looking forward to have your opinion. Yes, we have 10 panelists with us. Our first panelist is Dr. Krishna Dahiya ma'am. Ma'am is a professor at Pandit BDS PGIMS Rohtak. She is the secretary of Rohtak Fogsi branch. She has a teaching experience of over 30 years and over 110 publications to her credit. Welcome, Krishna ma'am. Our next panelist is Dr. Madhulika Singh ma'am. Dr. Madhulika Singh is a senior consultant in gynecology and hysteroscopy and laparoscopic surgeon at Shivam Hospital, Varanasi. Ma'am is specially interested in infertility management, hysteroscopy and endosurgery, as well as colposcopy. She has been the past president of Varanasi Obs-Gynae Society. Welcome, ma'am. Our next panelist is Dr. Priyanka Garg. Dr. Priyanka is a consultant obstetrician and gynecology and endoscopic surgeon at Newtema Super Speciality Hospital at Meerut. She is also the secretary of the Meerut Obs-Gynae Society and the North Zone coordinator for the Spina Bifida Foundation. Welcome, Dr. Priyanka, ma'am. Our next panelist is Dr. Alka Yadav, ma'am. Ma'am is a consultant gynecologist at Shanti Hospital, Narnaul. For over 28 years, she has been practicing. She is also the president of the Rewadi Obs-Gynae Society and a member of the Public Awareness Committee of Fogsi. Welcome, ma'am. Welcome, Alka, ma'am. Next panelist is Dr. Sangeeta Singhal, ma'am. Dr. Sangeeta has over 30 years of experience. She is a former senior consultant at PGIMS Rohtak as well as consultant at Malabar Hospital, Rohtak. She is the president of Haridwar Obstetric and Gynecological Society and the past secretary of Roorkee Obs-Gynae Society. Welcome, Sangeeta ma'am. Our next panelist is Dr. Nishi Garg. Dr. Nishi Garg ma'am is the director of Garg Multi-Speciality Hospital at Faridkot. She has been the ex-professor of PIMS Udaipur. She has over 34 years of experience. She is the president of KFOGA Society as well as the member of MTP Committee of Fogsi. Welcome, Nishi ma'am. Our next panelist is Dr. Amita Gupta ma'am. Ma'am is formerly the professor and head of PG department at Obs-Gynae at GMC Jammu. Ma'am has been the winner of the Fogsi Achiever Award as well as the officer in charge of HRRC under ICMR. Welcome, Amita ma'am. Our next panelist is Dr. K.R. Parashar. Dr. K.R. Parashar is one of my fellow consultants at Nova IVF Agra. She has been the ex-senior resident at DDU New Delhi as well as the ex-registrar of Apollo Roya New Delhi. She is the author of multiple papers and an active member in multiple national and international CMEs. Welcome, Dr. K.R. Our next panelist is Dr. Kiran Chandna ma'am. Madam is the president of Faridabad Obs-Gynae Society and member of the Fogsi MTP committee. She has special interest in adolescent health and contraception as well as an active member of Fogsi and Haridwar Obs-Gynae Society. Welcome, Kiran ma'am. Our next panelist is Dr. Parul Gupta. Dr. Parul is a senior consultant and IVF specialist. Again, one of my colleagues from Nova South End IVF Center at Vasant Vihar. She has been the ex-assistant professor at D.Y. Patil Medical College, Navi Mumbai, as well as ex-consultant in OBGY at IVF Kailash Hospital. She has been recipient of various awards, including the ISAR Mayor Youth Icon Award in 2023. Welcome, Dr. Parul. So over to you, Bharti ma'am. Once again, my apologies for not being able to co-moderate the session with you. Over to you, ma'am.
Thank you. Thank you, organizers, for having me here. So I'm going to share my screen. Okay. Is it visible?
Yes, ma'am, visible. Just make it full screen.
Yeah, I'm making it full screen.
Yes, ma'am.
So I just wanted to know from the organizers about the timeline that has been given to us for this panel, actually. Hello?
Yes, ma'am.
May I know the timeline that has been given to
Yes,
me?
ma'am. 40 to 45 minutes.
Acha, 40 to 45 minutes. Okay. So without wasting further, I just start with the polycystic ovarian syndrome. Polycystic ovarian syndrome is one of the most common disorder. Yes, we do understand that it has so many basic etiologies related to our lifestyles, related to our environmental toxins, and related to the obesity and other things. And it is one of the epidemic these days. Incidence in India, yes, it has a higher incidence of around 1 in 10 in reproductive age group, 2 in 10 in adolescents. And we can see that rural population, as compared to the rural population, urban population is affected more because of the changing lifestyles and environmental toxins and exposure. So incidence definitely is on rise. We all know that. So without further discussion, we just move on to the case number 1. So there is a 13-year-old girl that reports with her mother to a gynec clinic. Mother is very apprehensive, worried that my daughter has started menarche 9 months back, but she is having irregular cycles. Her cycles are 4 to 5 days. They are coming at an interval of 45 to 60 days, but no, and now this time she didn't have period for past 50 days. Her BMI around 26, mild acne on the face is there. But she doesn't have any other medical and surgical problems. And one ultrasound is there, and that is suggesting that multiple follicles in both ovaries. Otherwise, uterus is normal and shape and size. So the mother wants further counseling, any kind of treatment or anything further to be done, whether it is worrisome or what advice we need to do. So moving further, what is the diagnosis? So may I ask Dr. Krishna, please?
Yes, ma'am. Hello, am I audible?
Yes, ma'am, you are audible.
She is a 13-year-old girl who is just started menarche 9 months back, and her main problems is cycles. They are irregular, means they are coming at 45 to 60 days.
Yes.
So just she is a case having irregular cycles, slightly obese, BMI is 26, and mild acne is there. So she is a case of I think the menses in this age group, these are the normal menses.
Okay.
This is a normal because hypothalamic HPO axis is still immature, and that will take around 2 to 3 years that the cycles will set. And this is just a pubertal transition is there. And this mild acne is also in adolescent age group. This is also quite normal, and that too is a mild one.
Okay. Thank you, ma'am. So I would like to ask Dr. Madhulika if she is agreeing upon Dr. Krishna's statement that this is likely a normal variation of a physiology. So would you like to investigate her further, or would you say that this is like a physiological variation? We just wait and watch. So Dr. Madhulika, please. Dr. Madhulika? Am I audible?
Yes,
Is Dr. Madhulika available, or I can ask then Dr. Priyanka Garg if Dr. Madhulika is having some problem in joining. By that time, we can just move to Dr. Priyanka. Later on, we can have some other question from Dr. Madhulika. So Dr. Priyanka, are you there? Hello.
Ma'am, you are audible. You can ask somebody else. Maybe.
Okay. Then I want to ask anyone who is available, please. Dr. Nishi, Dr. Amita,
Yes.
Who is there, please?
Dr. Nishi here. Dr. Nishi.
Yeah, Dr. Nishi, I would like to know that you go in statement with this Dr. Krishna that yes, this is a normal physiological variation, or do you think that we need to investigate before we jump up on our diagnosis saying that this is a physiological variation?
So she's right. Within first year, it is always a disturbed HPO axis which gets settled after 1 year. So, but
Yes.
once the girl has come to us, so we should first reassure her. And for her BMI, we must advise her dietary pattern, exercise, yoga, and other things. And if at all
Okay.
we need investigations, we can go ahead with general examination for anemia, for her glucose tolerance test. And at the same time, we must advise her the HPV vaccine, which is very important in our day-to-day practice. And if at
Okay.
all needed, we can just advise her one simple ultrasound just to see any pathology in the uterus or
Okay.
adnexus.
Ma'am, any other hormonal profile would you like to see? Because yes, we presume it is related to an ovulation because there is a disturbed hypothalamic pituitary axis, but there are other causes of an ovulation.
Yes, yes.
And
We can go ahead with thyroid profile, with serum prolactin
yes.
levels, with serum these will also be helpful in reaching to some decision. And
Okay.
more important
ठीक है.
is her reassurance
Can I
regarding.
add something, Bharti, over here? I'm Dr. Rakhi here.
Yeah, please, ma'am.
Basically, HPO axis, for it to be getting settled, it takes around 3 years. And before that,
Yes.
there is nothing what we have to do for that except for reassurances. And if the patient is having a higher BMI, we need to ask the patient, that is an adolescent girl, not only the girl, the parents also need to be counseled along with the girl for the high BMI, that a BMI has to be corrected, the correct diet has to be taken, and lifestyle modification has to be done. And
Okay.
nothing from that. Apart from that, no other test is required at 13 years of age. And if suppose she is going into androgen excess, then also we cannot label this patient, adolescent girl, as a PCOS, because at this age, we need to write down till the time she finishes her 8 years post menarche, we need to tell that patient that she is at risk for PCO. If suppose she is having any symptoms of acanthosis nigricans, insulin resistance, hirsutism, or any other symptoms, the symptoms going to speak volumes, but still with those symptoms also, we are not going to write down that she is PCO positive. We're going to always write down these adolescent children that she is at risk for PCO. First point. And ultrasound is not at all required for these patients because HPO axis needs at least good 3 years post menarche to get settled. As it is in that age group, the patients would definitely have multicystic ovaries, which are the normal ovaries, and
Yes.
they take some time. How to differentiate between a multicystic ovary and a polycystic ovary is the cortex is thickened over there. And whereas in multicystic ovaries, the cortex is very thin. And though they are purse strings, in polycystic, here they will not be purse strings. They would be randomly placed here, there, everywhere, all around in the ovary. That are the diagnostic signs.
Yes. So as per going by the guidelines, these are the ASHRI SRM latest consensus saying that how do we define as an irregular menstrual cycle? So post menarche, any kind of variation within first year after presuming menstruation is taken as a normal prepubertal transition. But when she has a menarche years from 1 to 3 years, then if the cycles are less than 21 days happening at less than 21 days interval or more than 45 days, then you can say yes, she's having abnormal uterine bleeding. Similarly, post 3 years after resuming her menarche, if the cycles are less than 21 years interval or more than 35 days intervals or less than 8 cycles per year, you can say that patient is having irregular cycles. So these are the few definitions which has been given for us to basically standardize our treatment, standardize our diagnosis and approach to a young girl, adolescent girl who approaches to us for irregular menstrual bleeding. So regarding counseling, Dr. Rakhi has already said that holistic, sensitive and comprehensive management approach is must. Obesity and cosmetic concerns, yes, they can lead to poor self-esteem and depression. So we need to actually target, but these females are definitely at PCOS risk. So because of their high BMI, and we said that almost there are increased hair growth, which we can see on the face. So they are at risk. So definitely that lifestyle changes and targeted interventions has to be given to the patient. So mood disturbances, yes, these patients can have a mood disturbances and other things. So targeted emotional counseling and psychosocial counseling has to be given to these patients. Why the diagnosis of PCOS is difficult in adolescents? So may I ask Dr. Amita or anyone who has joined, please? Dr. Amita.
Good evening, everyone. Am I audible?
Yes, yes, ma'am, you are audible.
It is the diagnosis of PCOS difficult in adolescents because soon after puberty, the menstrual irregularities, they are there. Number one. Number two, post-pubertal acne is also there. Number three, and that adolescent fat is also there. So the diagnosis becomes a bit difficult. We have to be very careful in labeling the girl as having PCOS. So as in previous slides, it is discussed that we have to give margin to the irregular cycles, to the acne, and we have to take a complete history, and we have to just be cautious in telling the girl to have a good lifestyle, active lifestyle, and be conscious about her diet. So that is why the diagnosis is a bit difficult.
Okay, even ma'am, as the Dr. Rakhi said, that even sonological appearance is not concluded
Yeah,
because they have a
same.
small
And
polycystic ovaries.
minute differences there
Yes,
regarding the
all these
echogenicity.
features, yes, which are the standard criteria for diagnosis, they can have a normal physiological appearance in the adolescent group. So the features can be overlapping, but this cannot be as such concluded that she is having a frank PCOS. So moving next. Yes, PCOS diagnosis in adolescent, up to 75% girls report cycles of 21 to 45 days duration in first year. Regular menstrual cycles are usually achieved 2 to 3 years post-menarche, and there can be a acne, as already has been said by our expert. The pelvic ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age of less than 8 years post-menarche. A polycystic ovarian morphology in these females can be seen up to 40%, 35%, and 33% of the patients when assessed at 2, 3, and 4 years after menarche. So this is important to note down that ultrasound should not be used as a criteria to define as a polycystic. So yes, I think all our panelists, they agree that this is a normal transition. It appears to be a normal puberty transition. Since she has come to a health facility routine checkup, yes, we should be looking upon other factors, but other important morbidities which can be common in our Indian scenario, and we have a chance to counsel the female for that. So she should be looked upon for the anemia, regular exercise and nutrition. Yes, she is obese. And mother should be counseled for nutrition, HPV vaccine for the daughter, and pap smear and HPV vaccine if she is sexually active. So coming to the case number 2. So our panelist wants to add anything for the case number 1, or should I move to the case number 2?
I think the hyperandrogenism should be differentiated from the physiological hyperandrogenism in these patients.
Yes, but our first patient hardly had any physical appearance. So, yeah. So probably
she has mild acne only that comes in the physiological.
Yes. But definitely, if it is their hyperandrogenism, that hyperandrogenism definitely need evaluation by various parameters, by physical examination, even by the biochemical parameters.
Yes.
So now we move on to the case number 2. 17-year-old girl, 11th standard student, presented with frequent cycles since past 6 months after she had joined a coaching class. Flow lasts for 5 days and cycle length varies from 15 to 18 days. It means they are basically coming at frequent intervals. She had menarche 5 years back, but on seeing her, there is no acne, there is no hirsutism. Patient had history of weight gain in last 2 months. Her BMI is 26. She is towards higher weight parameter side. Thyroid parameters have been already done. They are normal. There is no clinical evidence of hyperandrogenemia, but yes, some other endocrinological parameters have been evaluated, and her TSH is 4.2, prolactin, FSH, LH, serum testosterone level, they have been done and found to be normal. Even her sugar profile is totally normal. So what we think that, what is the probable diagnosis, what type of case we are dealing with? So may I ask Dr. Kiran Chandra, please? Dr. Kiran, are you there? Or Dr. Parul? Dr. Parul, Dr. Kiran, then Dr. Kia. Dr. Kia?
Yes, ma'am. I'm here.
Yeah, please.
This is the patient who has had her menarche more than 3 years back, 5 years back, and though she doesn't have any hyperandrogenomic features right now, but she is at risk of PCOS because her BMI is high, and cycle length is also a bit variable. So she is not PCOS per se right now, but I would say she is at risk of that, and because she also has weight gain, 3 kg weight gain. Other investigations, and as you said that she just joined the coaching and then after that she gained weight and she has irregular cycles. I would, of course, if she has missed her periods, she is even slightly overdue, I would of course like to do a UPT and prolactin and other tests for an evaluation, and I might add a pelvic ultrasound in this case.
Okay. Okay. So what exactly you want to look for the things in the pelvic ultrasound, ma'am?
Ma'am, I would want to see any cyst or
First
something.
of all, this has been mentioned that she joined a coaching and after that she has some irregular period where the cycles have become frequent. This could also be because of the stress, because at times stress also plays a very important role when the cycles become irregular. And because of the stress, sometimes there is bulimia also when kids tend to overeat, and that is also one reason when the weight gain also is there and the cycles become irregular.
Okay. Yes, there can be definitely any stress, any anxiety that indirectly affects our hypothalamic pituitary axis only, so leading to an ovulation and other kind of irregular cycles. So we think it can be definitely one thing could be that it can be related to stress, but we still feel that by definition she has irregular cycles, but at present she is not fulfilling the criteria of PCOS per se, right? But she is the one who is at risk of PCOS, having that irregular cycles along with her higher BMI. So yes. So how are you going to counsel her? Are we going to start her on any kind of treatment, or it is just a kind of counseling that will suffice at this moment?
Actually, I would like to counsel her right now. I would try to tell her to reduce her weight, try to moderate her diet, try to do some exercise per day or at least some exercise per week, and meditate so that her stress levels also go down, because of course, as Parul ma'am very rightly said, that this is the age when the stress is at its peak, right? Probably. So I will do that, but probably I would also like to examine her for anemia, but I won't give her any other hormonal or other medication per se right now.
Okay. Dr. Nishi, does she need any follow-up? Dr. Nishi is there?
Follow up after her, once she loses her weight and still if the periods are irregular, then at least we should follow up for regularly for PCOS. We should keep on evaluating her later on.
Okay. So how long we
Most
think?
important, but most important is lifestyle management, because we are seeing such type of cases very often in our OPD practice.
Yes.
So
Yes.
once you come to know their diet, I just start writing what are you taking in the morning. So most of the people are taking this burgers and other things. So if you
Yes.
tell her to restrict carbohydrates and increase the protein diet, definitely it helps in the weight control and regularization of periods.
Yes, so we need to counsel her for lifestyle changes, exercise, lose extra weight, and definitely menstrual cycle re-evaluation can occur over 3 years post-menarche, where only menstrual irregularity or hyperandrogenism are present initially. Evaluation with ultrasound can occur after 8 years post-menarche. So this is a kind of lifestyle modifications we are going to tell this girl. The first therapeutic recommendation involves discussion with the girl and the parents and encouragement of appropriate dietary and exercise interventions, especially for overweight or obese. So that can be in form of diet, exercise, yoga already said, sleep, even routine. Sleep is also a very, very important factor to have a normal weight, because even a less or a more sleep both can cause the more weight gain. Psychological support for anxiety and depression and routines. So what kind of exercise we need to tell her in a practical way, that you do this or you do this kind of exercise for so many, how many minutes as per the ASHRI or latest recommendations? So can I have this answer from Dr. Krishna, please?
Yes, lifestyle modifications, they are very important. Exercise in the form of she can do an aerobics, or she can brisk walking. She can do at least 30 minutes a day, start from the 15 minutes, and slowly she can increase up to 30. And even we can ask if she is enjoying dancing, swimming, anything she can do. But our main aim is that she should do exercise, maybe in any form. And the weight reduction is also very important. Dietary modifications are to be advised. In the diet, we should tell her that more fruits, more salad, more vegetables, more sprouts that should be taken, and consumption of alcohol, smoking, coffee, that should be avoided basically.
The big no to the junk, right?
No junk food is to be given.
Yes.
So basically, mother and daughter both are to be counseled. Only then that will be helpful.
Okay.
I think more mother is to be counseled. Mothers need to be counseled.
Yes,
I think
mother.
exercise in any form.
Exercise
we
in any
enjoy
form,
it,
and
whether that can be a walking or a dancing, swimming, anything, yoga, whatever. But at least half an hour a day is must.
yes, and if you look at the latest recommendations, so they have categorized that exercise into a mild, moderate, and vigorous activities because they are the weight wise actually. So, what kind of weight reduction we are anticipating from which BMI? So, they are basically have to be told to the patient that she needs at least this percentage of weight to be lost, and this kind of vigorous activities, whether she need a moderate kind of activity or only a mild kind of activity will suffice. So, we need to emphasize on that exercise pattern also. So, I think from the panelist, we are now clear that this patient needs counseling, counseling, and counseling. And yes, counseling that this patient can be at PCOS risk, need frequent follow-up. We have to focus on her lifestyle, mainly and dietary interventions and frequent follow-up to look whether this patient has any response to the lifestyle or whether she is doing them in a right or a wrong way or whether she is finally landing up into a PCOS female. So now moving to the case number 3, the same girl is coming to us after 10 years. Now she's 27 years. She has a hectic job profile, 12 to 14 hours every day. She followed the weight loss advice and her cycles were regular. But again, when she joined a job, she has again gained the weight and her cycles are now again become irregular. She's having the cycles in an interval of 50 to 60 days with slightly heavy flow, and BMI is now increased to 28. So looking at her, she looks that she has a hair growth increase, hair growth on her lip, chin, and few hairs are present on the lower abdomen, back, and thighs. Acne have also developed, and patient is conscious that she feels bad about her looks. On examination, the hormonal profile is coming normal, and she's married for 3 years this time. So she is worrying about her looks also, and she wishes to conceive. So what we think that what should be the ideal management at this age for her, because she has come for major 2 issues that she needs her cycles to be regular, she wants to improve her appearance, and she wants to conceive. So may I ask Dr. Kiran, Dr. Kiran is there?
Yes, ma'am.
Yeah, please. Dr. Kiran would like to hear from you. So what do you think that how we should basically approach this patient or start evaluating her?
For this patient, lifestyle management is very, very important. Along with the other treatment that we have to treat for the hypohidronism, we have to treat for the acne, hirsutism, and we have to treat for the insulin resistance also. And this patient, they have got subfertility also. They have to be treated for all these things in a go. That she should reduce weight. She should take proper diet, which is low in carbohydrates, high in proteins, and high fiber diet she has to take, and she has to lose the weight also. She has to, for the irregular period, she has to take the OCPs also, and for hirsutism, and she may have to be get the investigation for testosterone levels and LHS, FS. She has to get it done. Serum androgen, DHEAS test, they have to be done, and ACTS, and she has, for hirsutism management, she has to get the shaving, bleaching, electrolysis, etc. And she has to get the hormonal treatment also. For the management of period irregulation, she may be given Dyne therapy, Dyne treatment for the regulation of period. This is going to release the part of the hormonal disturbance also. And for skin specialist is to be taken consultation accordingly. And as far as planning of pregnancy is concerned, if you want, because such patient they have some fertility, they should be given treatment for the fertility also. And we have to see what is more important for such patients, because we have to treat all these things. Otherwise, she will have less of the lot of problem in life.
Okay. So, Dr. Parul is there?
Yes, ma'am.
Yeah, Dr.
Yes.
Parul, how will you take care of her infertility aspect? So, what do you think? First, we think that as the madam said that first we will target her weight reduction.
So, as ma'am rightly said, but the very important point here is there are too many things which she is wanting to correct at a time. So, we cannot correct hyperhirsutism or acne and irregular periods at the same time when she is wanting to plan a pregnancy, because one thing is there that for some issues like hirsutism or acne or irregular periods, at time we do give OTC pills, then somebody stops.
Please, yes. I request all the participants
Dr.
to
Shatabdi, can you mute yourself? Can somebody mute? Yeah, please. So that is one thing that we have to ask her what is her priority. If she's prioritizing on correcting her irregular periods or hirsutism and all, then we move ahead in that direction. Very rightly, in all PCOS patients, the treatment begins with lifestyle modification by correcting diet and weight and everything. But many a times, when patients come to us and then they also know, they are also aware that they have to lose on weight. But even if they are unable to do so, then also we have to go ahead with the treatment. So the treatment for infertility issues also starts with lifestyle modification. We have to tell them that it is not necessary that they come when they've shed say 10 kgs or 20 kgs. Even a 5% of weight loss at times helps in restoring ovulation. So if with the lifestyle modification and weight loss she has, and we can add some simple medicines like metformin or some other medications. If the ovulation is not restored, then we can move on to adding ovulation induction. So we can tell her to come after some time, and then we can start with correcting the ovulatory dysfunction by giving her ovulation induction.
Okay, so I think our panelist feels that definitely the first line intervention, whatever the issue is, whether it is irregular cycles or whether it is an infertility concern, the first thing is that we have to tell her to reduce her weight by modifying her lifestyles, doing yogas and other exercise, and at least 5 to 10% of losing the weight will be suffice for improving her cycles and even help her for the conceiving. Another important thing here, yes, we need to understand that patient has to be counseled in such a way that if she wants the regularity of cycles and we think of prescribing OCPs, that we need to counsel the patient that she is not going to conceive because we are giving her a kind of contraceptive pills. Another way is that, yes, a patient has a fertility concerns, but she's definitely come up after 3 to 6 months saying that I have lost a weight of around 5 to 10% of her original weight. Then another important thing is, yes, by giving the ovulation induction, when she ovulates, she's going to have a regular cycles in that way also if it doesn't conceive. But the counseling is very important, that what is the primary desire of the patient and what should be the first intervention for that patient to have an optimal outcome, either in form of improving her BMI, improving her hirsutism, and improve chances of conceptions. So rightly said. So what kind of medical therapy we feel that this patient should be given if she feels that, yes, I want to reduce my weight, I'm ready to do that, but after that I want a fertility. I want or any kind of fertility treatment. I don't want my cycles to be regular in such a way. So madam, what should be our ideal advice in this case? Are we going to start her on anything that can help her for reducing the weight or reducing her insulin resistance, or are we going to tell her just you reduce the weight and then come to us after 3 to 6 months? So anyone?
The best thing
start with giving,
start her on metformin.
Yeah.
That will improve the insulin resistance also and will help her in reduce the reduction of weight also.
Yes. So I think there are certain guidelines now that for the females who are trying to lose the weight, yes, metformin is going to help them to basically they optimize their hormonal milieu also, and definitely help in reducing to some extent the weight also. And after that, giving the metformin and it is lessen the insulin resistance, and then we can think of further giving her the ovulation induction, which the chapter already have included, and they told about the kind of oral ovulations which are available. So anyone can explain that what is the association between hyperandrogenism and insulin resistance? So why it is like so? Can anyone explain?
We all in patients with PCOS or who are generally they are patients who are obese as well. It is seen that they have insulin resistance. Now, because of this insulin resistance, the insulin level increases and it acts on the liver. When it acts on the liver, there is secretion of insulin-like growth factors which act on the ovarian theca cells, and we all know that the theca cells leads to increase in the LH hormone. So we have seen that the ratio of the LH or FSH in the PCOS women is usually 2:1 or 3:1. Whereas the LH is on the higher side, they have increase in LH. This LH also leads to increase in the androgen activity. So these patients have hyperandrogenemia. Also because of the when the insulin acts on the liver, it leads to reduction in the sex hormone binding globulin. So there is increase in the free testosterone levels also. Because of this increased androgen activity, and these patients have polycystic ovaries, so none of the follicles becomes dominant because of the lack of the hormone. There are many follicles, but ovulation does not happen because at times dominance of the follicle is not seen, and hence the cycle becomes anovulatory. So with these small follicles secreting some amount of estrogen, the lining becomes thick and then it sheds, but ovulation does not happen. So the cycles are anovulatory, the cycles become irregular, and also because of anovulation, they have problems in conceiving, that is infertility happens. And because of this hyperandrogenism, there is hirsutism, there is acne, thinning of hair, hoarseness of voice, and increased insulin leads to acanthosis nigricans, where there is darkening of the or hyperpigmentation of skin in areas like neck and underarms and these regions. And later on, then these patients can have metabolic syndrome.
Thank you, ma'am. You have beautifully explained the consequences of hyperandrogenism and insulin resistance. So, use of any insulin sensitizer in this woman, if they have a hyperandrogenism, they have insulin resistance, apart from metformin, anything else we can use in these females? Any comment on myo-inositol?
It can be added where there is combination of this 2 myo-inositol and D-chiroinositol. So if we give a combination of this, that can be beneficial along with that metformin.
So basically, myo-inositols, these are basically vitamin B derivative. These are like sort of plant-based things. And in patients with PCOS, the conversion of myo-inositol to D-chiroinositol does not happen. So basically, we give a combination of myo-inositol and D-chiroinositol in the combination of 40:1. There are newer drugs wherein the strength is even more than that. So there may be at times no benefit of giving myo-inositol because there are various studies. Some say that initially when the pharma came, they said there is a lot of benefit of adding myo-inositols. But since it is a vitamin B complex sort of drug, so at least there is no harmful effects of giving myo-inositol. So in patients, if metformin has not worked, we can add on myo-inositol and D-chiroinositol combination. And there are combinations wherein a single tablet myo-inositol is available with metformin.
Yes.
I think
these are very costly
myo-inositol, they are
drugs.
better tolerated as compared to metformin because they have no GI side effects.
Yeah, the mainly side effect of this metformin is GI. Most of the people,
Yeah.
they vomit it out while eating, so they don't feel comfortable. Yes, inositol has some added advantage, and definitely there are a few
And
recommendations.
they are very costly also.
Yeah.
But they are very costly, yes.
They are costly. Yes.
So it is better to stick to the basic insulin sensitizing agents like metformin, triglycerin.
The patient also say that they are not diabetic. Why you are giving the anti-diabetic drug to us? This
We
is the
have
main
to
problem.
explain to them. We have to explain to them.
We explain to them because this is a common question by the people.
So similarly, sometimes young unmarried females, they ask about OCPs, the same question.
Yes.
I think this is metformin is quite helpful in reducing weight also. So they can be convinced, those obese patients, they can be easily convinced that weight reduction will be there.
Yes. Maximum weight loss with metformin is not more than 3 to 3 kgs.
Yes, it is 2 to 3 kg only. It is 2 to
if
3.
they keep on taking it every month, they are going to lose weight. But also metformin helps in prevention of miscarriages also. So that is also when even after the patient has conceived, at times it is continued.
Yeah, if they conceive on metformin, that should be continued in the antenatal period also.
Okay. So any take on NAC, or anybody has used NAC for as an insulin sensitizer for these patients? Because I don't have any experience and we usually don't give it.
Yeah,
So
we have
anyone has
not also not used.
Yes, as such, there is no frank recommendation. It is the data is still investigational.
These are all accessory drugs,
Yes,
fancy
these are all
drugs.
accessory drugs. So not to be used as such without any other frank indications. So what are other concerned in a PCOS females we are bothered about? Like it is just that her irregular cycles or her hirsutism or her infertility that we are worried about, or are we need to counsel her for other long lifetime morbidities that has to be chased at present moment? So I think Dr. Kia can tell us about this. So, what is our concern in a PCOS female? Is it just a short-term outcome, or we are bothered about? Yes.
Sorry, ma'am. Actually, my network is missing, so I'm just continuing with the audio.
Okay.
The main concern with PCOS does not only lie with the anovulation; it also goes on.
It's a long-term outcome. Basically, the patient is obese.
Sorry.
Yes,
Yeah,
ma'am.
the
Yes.
is
So, ma'am, it also goes on in the till the perimenopausal age to the for metabolic syndrome, and then if it acts as the first stepping stone for further diseases like diabetes, hypertension, and atherosclerosis also. So
Yes.
it is a concern. It is a concern for obesity, hyperglycemia, and a precursor for hypertension also.
Yes. So now,
Ma'am, also we should not ignore mental health and body image issues in these females, because metabolic syndrome comes on later, but during their reproductive and adolescent phase, they have to deal with that body image issues because of acne, hirsutism, and thinning
even
of
we can have a
hair.
severe anxiety, depression, because I have two
Sleep pattern, yeah.
two young girls are coming to us with the PCOS, and they have a severe depression and anxiety, and they are on antidepressants actually. So the extent is too much sometimes. So we need to actually chase every aspect, every parameter. So now moving to the final question of the today's panel. So there is a 42-year lady. She is having irregular or missed periods. Mood changes are there, thinning of hair on the head, excess hair growth on the face and body, weight gain, depression. So is it only perimenopausal transition, or the symptoms are mimicking like that of PCOS? And what should be our line of evaluation for this female? So Dr. Madhubala is there, or Dr. Alka? Can you please answer, Dr. Alka?
Ma'am, please unmute yourself.
My connection was unstable, so I've not been able to
We are
hear the
able to
last
hear
part.
you, ma'am. We are able to hear you.
Actually, could you please repeat the question?
Yeah. I'm just saying that there is a 42-year female. She has come to us with irregular cycles. She says that I am having mood changes, depression, my hair are becoming thin, and she has noticed that excess of hair growth is there on her face and body. She has a kind of weight gain. So what we think? Is it a symptoms mimicking PCOS, or is it just a normal perimenopausal transition? So what should be our line of evaluation and management for this patient?
Actually,
Ma'am, you are muted again.
yeah, actually, there is some problem with my connection.
Your connection is probably unstable.
Yeah, it is.
Yeah. So if madam is not able to connect properly, so can I ask Dr. Amita? Dr. Amita is there, please?
Yes, actually, we have to differentiate between the perimenopause and the symptoms of PCOS. Like if it is a perimenopause, then it will be more of hot flushes also, along with other symptoms. Whereas if it is because of polycystic ovary syndrome, there is more of skin changes like hyperpigmentation, acne, along with hair fall. But we have to take care of this, take care of our complaints. So, depending upon, we think whether it is perimenopause or if it is a symptom due to PCOS, we can treat accordingly.
Yes.
So but the main focus for both is lifestyle changes, because in perimenopause also we ask the woman to be more active and less spicy food, adequate rest, and be at peace with herself. And if it is more of a PCOS, then we can add drugs also.
Okay, yes. So I think in both ways, whatever the first line of intervention will be, first her psycho-social aspect need to be treated, and we need to have some improvement in her dietary content and in her lifestyle also. So, and whatever the factors in perimenopausal, as madam already said, that yes, there will be more factors in favor of perimenopausal transition, that will be like in form of hot flushes and other things. However, in PCOS, we can have a different spectrum of the cases as compared to the perimenopausal transition. So the similar symptoms which can have with the PCOS as well as the menopause, yes, they both will have a irregular periods, because these in the both spectrum of diseases there can be an ovulation. And difficulty becoming pregnant, yes, because now she is perimenopausal, and ovulation and other things, mood changes, difficult sleeping, thinning of hair, excess hair growth, weight gain, and depression. So we need to be actually really vigilant enough to basically a diagnosis of the cases. But differences will be like that acne and darkening of skin, that will favor the diagnosis of PCOS, and hot flushes, night sweats, that will favor the diagnosis of your PCOS. So eat a diet full
And
of...
the only difference is I don't think so. Patient will come directly at the age of 42
Actually, we
with
have not
symptoms of
seen
PCOS.
late
Maybe
onset
she
PCOS.
might be aware of that. Maybe she might, because all of a sudden at the age of 42, she cannot have all these symptoms. She
Ma'am,
might be having symptoms. So that way we can come to know that she already had PCOS.
Yes.
Because otherwise, if she comes suddenly, then it is going to be perimenopause if she's directly coming at 42 with all these symptoms.
Yes, and then again we have to counsel her about her lifestyle, and what she needs to eat, what she doesn't have to eat, and quiet sleep and other factors. So we have already discussed that. So I think with this we finish the today's panel on PCOS. So anything any would like to comment upon or add on which we have missed, or any other experience they want to share? Or I would like to hear from Dr. Rakhi also, anything more to be added? And then after that, we can just wind up.
Thank you, ma'am.
So I think all our panelists, they have basically put a very strong point in favor of that. The first line of intervention, which is very, very, very important, is lifestyle. Lifestyle, and dietary advices. So this is in all kind, whether it is related to fertility, whether it is related to hyperandrogenism, whether it is related to irregular cycles. So I think this is a most important thing which has to be highlighted, that any patient with PCOS coming with any complaint, the first line of intervention should be have a healthy lifestyle, controlling her weight, and then targeting each and individual problem accordingly.
Okay.
Basically, an overall approach is more important, a holistic approach. That is the key to the PCOS management.
Okay.
So with this, I think I thank you all the panelists for the wonderful inputs, and thank you organizers for giving me this opportunity. It was a wonderful panel discussion and very interactive. Thank you so much.
Thank you, Bharti ma'am. Thank you for
Thank you.
wonderfully moderating the session.
Thank you.
To all our panelists for your inputs. Thank you to Rakhi ma'am. I would take this opportunity to thank the Fogsi leadership once again, Jaideep sir, Madhuri ma'am, Ajay sir, Dr. Kalyan, Dr. Priyankur. Thank you to our guests of honor, Dr. Uma Singh ma'am and Dr. Ashok sir. Thank you to both our speakers, Dr. Kuldeep sir, and as well as thank you to Dr. Sujata for letting us use her talk, the recorded talk. Thank you to all the chairpersons, Anita ma'am, Vidhu ma'am, Alka ma'am, all of you. Very heartfelt thanks to all of you on behalf of the Public Awareness Committee. Hope to see you all again with a new topic, with a new zone. Good night to everyone. Thank you all. And last but not the least, thank you Corona Remedies as well as Abhishek for helping us coordinate the webinars. Thank you all. A very good night to all of you.
Thank you. Bye-bye.
Thank you, ma'am.